Hello, I'm Will. Welcome to ResearchPod. Pain is rarely a welcome thing in life, but there are times when it is useful to prevent any further accidental harm. If you don't feel the pain you should, you're at risk of doing yourself greater damage. If you feel pain you shouldn't, that could be the first signs of a deeper issue, including, but not limited to, some neurodegenerative conditions. Today I'm speaking with Professor Rayaz, Malik and Dr. Ioannis Petropolous about their work on a new way of detecting those early stages of degeneration that is, non-invasive, inexpensive, and as easy as an optician's appointment. And if all that sounds too good to be true, just wait till AI gets applied to it. But first things first. And joining me to talk about their work, Professor Malik and Dr. Petropolous. Hello to the both of you.
Hi, this is Rayaz Malik, Professor of Medicine from Corneal Medicine in Qatar. I'm a clinician and an academic.
Hi, I'm Ioannis Petropolous. I'm an assistant professor of research in medicine at Corneal Medicine in Qatar. I'm an optometrist by training, and I've joined Prof. Malik's team back in 2009 to work on the corneal confocal microscopy project.
What is it about the field, the research that has drawn you to it in the first place and kept you invested all these years?
I think it boils down to my, previous life working in the field of nerve damage in patients with diabetes, which is a highly prevalent disease, has major issues in patients in terms of pain, in terms of foot ulcers, in terms of amputation. Really, the lack of a sensitive measure to assess nerve damage, one aspect, which would profoundly change how we deal with this condition. Because at the moment, what we do is we wait for the patient to develop these complications and then it's too late. And the other aspect actually is a really important feature of corneal confocal microscopy, which is that we believe that this could be a test that the FDA, if they approved it, could use it in clinical trials to enable a drug or new drugs to be approved for the treatment of diabetic neuropathy, which unfortunately we do not have at the moment. We have a 100% failure rate for clinical trials, and it's the frustration of that that has really kept me carrying on with this research.
Dr. Petropoulos, you said that you joined the team. Could I ask you to tell me a bit about the landscape for those failed trials and what has led to some of what we're talking about today, if we may be on the cusp of a breakthrough?
So basically, back in 2009, as I was doing my postgraduate studies, I got fascinated by what we call structure to function relationships. And I came across Prof. Malik's project at the time. What was, let's say, extra fascinating was the fact that it was going away from the classic ocular disease and it was looking at the systemic landscape of diabetes and the effects in the eye. So it was when I spoke to Professor Malik for my interview that I realized how important it is for the patients, for drug discovery, to have a new biomarker like this. And the rest is history. I joined the team, I worked on this project, and we found really interesting data that support the use of corneal confocal microscopy in diagnosis of diabetic neuropathy.
And Will, I just want to add, I think it was the exact opposite for me. Even still now, there are, I would say, dinosaurs in the world of neurology, even in endocrinology, who are not accepting of this complete paradigm shift where we're going to use the eye to look at neurodegeneration in the feet. How can that be possible? It's impossible. Or as we've now begin to show that actually we can use what is going on in the eye to look at what's going on in the brain. Sometimes I call this dogma, which is people are set in their ways, they will not change, and even if you present them the evidence, they will still say, but, and that but is the thing that is holding us back.
To look at some of the received wisdom, textbook knowledge at the moment, what is peripheral neuropathy in terms of how it comes about, who it comes about in, and by the time that it reaches you or any other clinician, what the standard current practice is?
Okay, so peripheral neuropathy is essentially damage to nerves. Now, what are nerves? Well, they are the structures that communicate you to the outside world. Because if you didn't have nerves, you will not perceive any sensation. That's actually what's called the somatic nervous system. Then there is the autonomic nervous system, which regulates how we breathe, how our heart kind of beats, whether we feel hungry, whether we are full enough when we've eaten too much. All of these signals are intrinsically controlled by the nervous system. And peripheral neuropathy is a manifestation of damage to actually both the somatic and autonomic nervous system. And so you can imagine, the patient who has the neuropathy, when their nerves are being damaged, they will feel pain. But when their nerves are completely damaged, they lose sensation. And you have people who literally cannot feel when a pan is hot or when they put on a tight pair of shoes. You and I, we put on a new pair of shoes. We're uncomfortable for the first few days until you wear the shoe in. Those people, they just carry on. And what is that uncomfortableness telling us? Well, it's telling us your tissue is being damaged. And if you can't perceive that, you can imagine how the patient can then develop an ulcer, complications, and they don't know about it. In fact, last week I was speaking to somebody, very, I would say, a business person who, the world, the guy's doing deals with companies, mega companies, and he's also a Manchester United fan. But he developed out of the blue painful neuropathy, and we're actually trying to work out what the cause of that is. But honestly, what he said to me really resonated, because you hear these stories. And he said, look, there was a point in my life where literally I would have been happy for people to have amputated my legs than continue with this pain. And that's how bad he was. And he was on multiple drugs. It's getting better now. So that's the painful side of it. And story, you get patient after patient who will tell you this. Of course, not every patient gets such severe neuropathy, but certainly a small but significant proportion do. And then the other side of it is the patient who walks into my clinic, whose husband is complaining of a funny smell, right? And they've got an ulcer that has developed on their foot. And honestly, this is a story that I heard a while ago when I was still a junior doctor. A patient had a nail sticking through the bottom of their, literally, the shoe, and they developed an ulcer, and they didn't feel it and had no idea that they had this horrible ulcer that was now becoming, infected. Those are the two extremes that you see. And I've had people who have, had local amputations without anesthetic. That's how, you can lose sensation.
Well, you'll forgive the pun, but from now we are onto the sensitive issue of pain. Dr. Petropolous, if you could tell me a bit about that in terms of not just the clinical presentation, but maybe some of the neurochemical signaling of how the body feels, manifests, does pain.
When it comes to pain, there's a whole range of reactions that happen. And as Prof. Malik said, pain is essentially a sensation that allows you to feel, understand what is happening around you. And with that, you have, secretion of proteins, neuropeptides that connect the nerves and they generate the signal, which is essential to feel pain. So basically, the way that pain is transmitted is through the sensory fibers. And that has been the focus of our research in Prof. Malik's lab over the past many years. So these sensory fibers, they're very small in size and they're located in the feet. And they connect to other larger fibers. And those fibers, they're supposed to send the signals up to the brain and feel the sensation of pain. And it is the point when these small fibers get damaged, circuitry doesn't work well anymore, which is something unfortunately very common in diabetes.
I was already flinching by the time you got to the ulcer because, just the idea of the smell, but when pain is a symptom, how does that connect to other related diseases? Because there's a lot of things that can cause pain, but knowing when pain is mediated by nerve damage or diabetes, chemotherapy, HIV, what is the kind of wider implication for pain, clinically speaking, there?
So pain actually is what brings the patient to the doctor. And a lot of pain can, of course, be inflammatory. You have damage to tissue and it's inflammation and it is going to give you pain. And it's actually what somebody famous once long ago said, pain is God's greatest gift to mankind because it alerts us to damage to tissue, to our bodies. The type of pain that we're talking about is something called neuropathic pain, which is driven by damage to nerve fibers. And that is a different type of pain in the sense that it is because of an intrinsic damage, not to the tissue around the nerves, but the nerves themselves are damaged and the signaling becomes abnormal. And the nerves themselves can be damaged due to a variety of conditions. So the commonest is diabetes. Why does that happen? Well, because in diabetes, you have this multiple metabolic abnormalities, high glucose levels, high lipid levels, abnormal blood flow from blood pressure, lots of abnormalities going on in the diabetic patient that can drive the nerve damage. And then once those nerves are damaged, they will signal abnormally and the patient will then perceive pain. But pain is a kind of a complex phenomenon because, one, you can have pain, I can have pain, but the effect that it has on us in terms of how we deal with it. And how do we deal with it? Well, it's actually to do with how our brain deals with it. So there are multiple, I would say, gating points, whether it's in the spinal cord or in the higher centers of the brain, which can amplify or can nullify the pain signaling. And depending on that, you can then have different people will react differently. So you can have some people like this guy that I've talked about, who said literally, cut my amputate, right? This is just too much. And there are other people who could probably maybe have similar degrees of pain who can manage to deal with it. And then, of course, you've got people who lose sleep, become depressed. So complicated, which is why we need an objective test.
That leads neatly onto my next question there, that with all of these centers that are activated, is there anything like a scale for pain in a chemical sense, useful biomarkers perhaps, from outside of peripheral neuropathy? Now, what's informing research for corneal confocal microscopy to develop the tests that you are working on?
So there are scales to measure pain. There are scales where patients can respond to what extent they feel pain, how much pain they feel, what kind of pain they feel. But through my research in Prof. Malik's lab, what I've seen is that these scales are highly subjective. So one day the patient can refer to one type of pain, and then at the follow-up appointment, the patient can refer to a different type of pain. That subjective element doesn't help very much to understand what is really happening, apart from realizing that the patient suffers from pain. Now, and this is where corneal confocal microscopy comes in as an objective test, which can help us understand if there is any structural damage to the nerve fibers, to the small fibers, which are crucial in terms of sensation, and then check if this damage is associated with the symptoms that the patient is referring to.
Yeah, and that's really where I get excited about corneal confocal microscopy, because we have other tests, so-called objective tests, and they've never really been able to, I would say, correlate with the presence of pain or the severity of pain. But we have shown in studies that in diabetes and also in chemotherapy-induced neuropathy, that actually the extent of corneal nerve damage detected by corneal confocal microscopy is related directly to the presence of pain. So if you have a cohort of patients with pain compared to those without pain with diabetes, they have more damage in those with pain. And if we furthermore grade that severity of pain into mild, moderate, severe, the more severe the pain, the more severe the damage.
Now, focusing on corneal confocal micro, can I say CCM for short? I hope so. Could you talk me through some of the process of the steps, the operations?
So CCM is effectively a camera for the cornea. You've probably come across during an examination at the ophthalmologist an instrument that they use where it flashes white light, and with that they can check your eyes. So basically, corneal confocal microscopy can take this examination to the next level. It provides very high magnification in it can check the cells and the nerves of your cornea and check for any signs of damage. So the process is basically very simple. All we have to do is that we have to apply a drop of anesthetic to prevent too much blinking during the examination. It doesn't dilate the pupils, and that means that the patient is free to do any activities immediately after the test. It has no pain. So basically, all it does is to come very close to the eye with minimal contact and capture very high resolution and high magnification images. We're talking about 600 times magnification of all the layers of the cornea, starting from the very first layer, which is full of cells, down to the nerves, and then more cells until the endothelium. And that can help us really understand if there's anything, particularly in the nerves, that are associated with the symptoms of neuropathy that we spoke about before.
Should one hope for a high score there, low score? Is it more like tennis or golf?
I think it would be more like tennis. So you're hoping for a high score. The higher the density of nerves, the more normal that it is for the patient. Of course, we know there is a threshold, and anybody who has above that threshold is within what we call the normal area. And everybody below that threshold, it can be either a suspect for neuropathy, or if it is too low, it can have confirmed neuropathy.
And to put all this in the context of diabetes care, I mean, going to be focusing particularly on diabetes, what's useful in terms of cure rather than just management. I've got notes here on pancreatic transplantation, bariatric surgery. If we could walk through some of those interventions then leading up to CCM as an outcome.
Okay, so, I mean, essentially, the reason why we did these studies is it was a proof of principle to show that if we can improve care in different ways of the patient, what impact will that have on the nerves in the cornea? And the first proof of principle study, actually, we were, I think, kind of almost forced to do it by the National Institutes of Health, where we applied for a grant and they said, well, you really need to show us what you're measuring changes or improves after you do something that's almost a cure for type 1 diabetes, which pancreas transplantation is. And we just happen to be in I would say, one of the best places in the UK. Certainly, Manchester is up there in terms of pancreas transplantation and kidney transplantation. We had a big diabetes centre, type 1 diabetic patients who were at end-stage kidney failure, need a new kidney for transplantation, but also they were undergoing pancreas transplantation. So in essence, in the words of one of my colleagues who's a surgeon, he said, Rayaz, you physicians, you kind of play with these patients. You don't really cure them. We cure them. And which is what they were doing. They were giving a new pancreas and essentially curing the underlying problem. And of course, that gives you the basis on which you can say, well, if you cure the diabetes, cure their blood glucose, then the nerves should repair. And that's what we did. We did this study where we took patients before transplantation and then followed them up over time. And we showed very clearly that corneal confocal microscopy, as opposed to a bunch of other what we call FDA approved measures, which is symptoms, signs, nerve conductions, didn't improve. Corneal confocal microscopy, within 6 months, it was starting to repair, show us repair. We could objectively measure it, and then it continued to improve. And it was about 36 months before the other measures started to improve. And, that gave us huge insights into how sensitive this test is to look for nerve repair. And similarly with bariatric surgery, bariatric surgery, people who are overweight, actually, people used to think that, they're okay, they're overweight, they're uncomfortable. But we actually showed that in people who are overweight or morbidly overweight, they actually already have a neuropathy. They have nerve damage, which they're not aware of. And when they undergo bariatric surgery, of course, bariatric surgery, you lose huge amounts of weight. But if you've got diabetes, you cure your diabetes, blood pressure goes away, lipids improve, and you'd expect that to have an impact on the nerves. And it did. And we were able to show within 12 months that the nerves were starting to repair.
And as well as being a score or scale for after treatment, where could CCM fit in terms of early detection, prevention even, for some of these conditions?
So again, this is a loaded question in the sense that it was the question that I was often asked by the dinosaurs in the world of neurology. Rayaz, but you're measuring all these things, it's abnormal, but does it really predict what happens clinically? And so we've done studies, several studies that all have taken people with diabetes without neuropathy, clinical neuropathy, as they would measure it with their nerve conductions, with their symptoms, with their signs. And we've then followed up, and this is actually a big NIH consortium study. We followed those patients over 4 years, and a proportion of those patients developed neuropathy, no surprise. And then what we were able to show is that actually the extent of corneal nerve damage at baseline could predict those people who develop diabetic neuropathy, with really quite high sensitivity and specificity. And we've done exactly the same, actually. It's a separate disease, but dementia. We've taken people who've got mild cognitive impairment and we've followed them up over 3 years. And we know that for sure, a proportion of those people with mild cognitive impairment will develop dementia. And guess what? Nerves were lower in those people with mild cognitive impairment who developed dementia compared to those who weren't.
And to see this fitting into wider clinical design as well to expand the utility, you mentioned about cohort selections for go, no-go is just a kind of a way to get a lot of information as early as possible. How many doors does this open for medical practice outside of just what we've talked about today?
Yeah. Honestly, in fact, yesterday I got an email from a rather big pharmaceutical company who are frustrated with the amount of money they've spent over the last 30, 40 years and the number of times they've failed in their clinical trials. And they were asking, what can we do to try and help improve the design of our clinical trials? And I said, one thing that you can really do is incorporate corneal confocal microscopy because, you can think you've got this drug and you're going to do a clinical trial are you going to do it for 4, 5 years before the current endpoints start to improve? No, because most pharmaceutical companies will want to do the trial within 18 months, 2 years. And they say, if it hasn't worked by then, forget it. The drug doesn't work. But that's actually not what they should be doing. Maybe they should be having CCM as a kind of a starting point alongside the other tests. If CCM within 12 months is starting to improve, then you can invest for a longer period of time and show that there's an effect. If it hasn't, then I suspect that you're on a drug that isn't going to work. So that's where the go, no-go signal comes in. That is really important because otherwise you end up doing this repeat, rinse, repeat, which is going to these trials, fail, and then say, oh, the drug doesn't work.
And physiology underlying those central conditions. Is there anything to look at? You mentioned dementia, but we've also had concerns about long COVID over the last 4-ish years. Is there anything that unites this kind of a body of central diseases that might be something that CCM gives us an earlier insight into?
Yeah, so specifically with regard to long COVID, we actually did a study in Turkey and we showed very clearly that people who develop long COVID have less corneal nerves compared to people who've had COVID but didn't have long COVID. And actually, for this study, as an academic, you're kind of like, you're bothered about impact factors and stuff, but there's something called an altimetric score, apparently, which is supposed to be good. And we were astronomical. We were like 1,600 or something we scored in that. Most papers score about 20. But it's because of the interest that we got, because genuinely, there are many people out there who have got long COVID and they are ignored by their physicians because it's not an entity we recognize. But there's a lot of, I would say, otherwise normal, driven people who suddenly their lives have been upturned, destroyed because they've got this thing, long COVID. And you think, well, why should you be having this? But it's because there is evidence of neurodegeneration.
From where I'm sat, I can see only upsides to this, and without getting into, let's say, wider reforms of the healthcare sector, what stops this being for everyone, everywhere? Is it a technology thing, research validation? What would it take to make the world fit CCM being used for all these kinds of possible applications?
First of all, without wanting to be upset anybody, I'd say we need to get rid of the dinosaurs. Once that happens, then we actually genuinely move and we make progress. Secondly, the company themselves, Heidelberg, need to make a cheaper, more rapid, more effective, non-contact corneal confocal microscope. And if they don't, somebody else needs to. And that I think would be a kind of a major game changer because it's access. Ideally, I would love to see this on every high street, right? People walking around. You're worried about whether you've got neuropathy from diabetes or from chemotherapy, or whether you might get dementia. You have this scan, it's an eye scan, and especially with the current use of AI, and we've got some amazing data now with AI that shows that we can not only pick up earlier changes with much better sensitivity, but also predict or differentiate different diseases. And that's always one of the kind of things that people come back to me and say, oh, you've done corneal confocal microscopy in diabetes, in this, in that, you find an abnormality. But now actually what we're showing with AI, we can actually differentiate different diseases. So with 100% sensitivity, I can tell you whether or not somebody's got nerve degeneration from Parkinson's disease, for example. And for multiple sclerosis, it's about 95%. For dementia, it's about 95%. That completely changes what we're doing.
Yes, that was in one of your newest papers, I think. Dr. Petropolous, if I could ask you for maybe a quick run through in terms of where you see AI in terms of that paper now and maybe the next 5 years, what's happening and what could come next, your ramp up from there.
Before I share my view on AI, I would just like to say that the way it started is, as a lot of these tasks, we tried to automate the analysis process and save us time so that we can perhaps look at more diseases, more patients, and in general, make things a little bit more efficient. So in the last few years, we've seen, I would say, an explosion of AI applications, and that includes the field of corneal confocal microscopy, the field of CCM, and AI has this almost, I would say, magical power to allow us to look at the images in ways that was simply not possible before. And this is because AI can analyze parameters that we as humans cannot. It can do complex calculations in the background. And I think with the development of explainable artificial intelligence, we can now see how the algorithm is making these decisions. This is definitely a game changer in terms of diagnosing early, screening patient populations, and of course, predicting outcomes. So I could honestly say that if we manage to integrate AI algorithms with the current hardware that we use to scan patients, that could be definitely, I wouldn't say the $1 million question, but the $1 million answer, in a sense that we can combine two very powerful techniques to help us at our goal, which is to diagnose earlier and prevent disease or treat disease. To add to that, apart from helping us look at the images in ways that we explained are not possible currently by humans, it can also help us differentiate between diseases, which is very important in the context of applying a diagnostic test, a biomarker, and be able to tell the physician that X findings come from said disease or Y findings come from a different disease. So this is definitely something that us and perhaps other groups are working on. We've been trying to answer this question, and I'm hopeful that we will.
I think that puts the two hurdles there of someone coming up with a non-contact version, Heidelberg or anywhere else, and then having an AI suite to access that, make the things work the kind of scale you're talking about. We've been talking lots about how well this is going and how useful it is for a lot of applications, but I know there have been some negative findings as well around neuropathy and how it compared with other measures. What does that mean in your eyes as to how this is useful as a biomarker for neurodegeneration?
Thanks for bringing up this important question. So we're aware that some recent studies showed some negative findings, in a sense that they either showed that CCM is not performing as good as other diagnostic tests, or that it doesn't correlate strongly with other measures like skin biopsy, symptoms, and signs. This is important for CCM because it is telling a story. It is telling a story about situations where CCM might work or may not work, as this is the case for all diagnostic tests. We also need to take a closer look to these studies and understand what led to these results. Is it a specific study population? Because we know that variables like diabetes duration, control of diabetes, medications, the age of the patient, the specific painful symptoms that they get can affect the outcomes. Or perhaps is the analytical approach that we use, which might have led to these results. In terms of the analytical approach, we are more capable than ever with the use of artificial intelligence tools to quantify additional metrics. So a question that arises is whether by quantifying these additional metrics, perhaps we can look at these results from a different angle and better understand more about the situations where CCM didn't work.
So something of a silver lining to those findings all the same.
And actually, Will, I would welcome all data, right? Because, sometimes if you just see positive, 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 then actually that's not, to me, science is not discovery. It's about having those challenges and then providing an explanation for why it may have worked or may not have worked. And when I look at those studies, there's one particular study that got published in a highly prestigious journal, Neurology. When I looked at the numbers, I honestly thought they'd made a mistake, a decimal place mistake, because they were coming up with, say, for example, a sensitivity for corneal confocal microscopy of 14%, which is unheard of compared to 99% of the data that's published out there, which all shows it's above 80%. But then the other counter bit of that was actually that specificity for CCM, or corneal nerve fiber length, in that study, it's the best I've ever seen it. It's 98%, something close to that. So that makes you think that there's something not quite right about that study. We need to ask questions as to what was the design of the study, how did they measure neuropathy? But as I said, I welcome negative results as much as positive results. That's how we move forward. Ultimately, people need to be aware that you've got this potentially powerful technique, which is not going to be inflicting any pain, taking any tissue out or whatever, but it's going to give you a very sensitive measure of neurodegeneration. So patients need to know about it. Other specialties, neurologists need to know about it. Ophthalmologists need to know about it. Endocrinologists need to know about it. Anybody who deals with neurodegenerative disease needs to know about this technique, because it really is, I believe, such a powerful way, an easy way of addressing the issues, the day-to-day issues that as doctors we face, which is about being able to diagnose a disease, being able to actually predict what's going to happen to that disease over a period of time, and if we have got therapies already, seeing if those therapies are working to help improve the underlying neurodegeneration. And if we have new therapies that where we think they're going to work, we can use it to test, evaluate whether or not they're going to work. Honestly, the technique is just beautiful. I mean, it's simple, it's non-invasive, and it has so many applications in terms of not just what we've kind of focused on, diabetic neuropathy, but multiple neurodegenerative diseases. And to me, when I look at that, I think, wow, if I was a person walking along and I had a worry or concern about maybe having a neurodegenerative disease, what would I like? I would like to just walk into my high street optometry shop, optometry place, and just have a scan, right? Rather than wait, which at the moment in the NHS, you're going to be waiting 2 years minimum to even get to see a neurologist, right? So, this could actually open the door in terms of you have a quick test, and then if it's positive, you then get, fast tracked in terms of referral. Otherwise, you're waiting. You've got these symptoms, and people are just not able to access, the medical system.
I would have to agree with Professor Malik on the use of CCM. I think it is wonderful, really, that ophthalmology comes to meet neurology and address a major challenge when it comes to diagnosis of diabetic neuropathy. I think we are proposing, and not just we, I think there's a lot of centers around the world that are using this technique with great enthusiasm. And we are proposing a test which is easy to use. It gives instant results. It provides a view that wasn't possible before in the nervous system. We are hopeful about the future of this diagnostic test and what kind of changes it might bring to the way diabetic neuropathy and other neurodegenerative diseases are diagnosed. And I would like to add to what Prof. Malik said, that apart from patients and doctors, I would like to add to that list funders and policymakers, because we can generate the data, and we have generated the data. I have joined this journey from 2009, and I have seen a lot of the data around CCM changing in a positive way, and we have validated the findings, but only if funders fund these larger studies and policymakers decide to make CCM, corneal confocal microscopy, as a diagnostic test for patients who have potential neurological issues, neurological complaints, only then CCM can really take off.
And for anyone listening to this who wants to know more about you, your lab, any specific publications, where can they find more? If there's maybe any websites or upcoming papers that you'd like to raise for their attention.
I would say in two places. We are very active on social media, and they can check our social media accounts on ENA Group, which stands for Early Neuropathy Assessment Group. And for anyone who want to have a deeper look, a deeper dive into the numbers, they can always read our papers who are published as open access simply by typing our names in a search engine like PubMed or Google Scholar, and a lot of the bibliography will come up.
Thank you so much for your time, and I look forward to speaking with you both again sometime soon.
Thank you.
Thank you, Will.